to you.
Hi, very good evening to all of you. Myself, Saurav, the head of marketing from Samarth Oncology. Today, again, we are together with our very renowned and well known medical oncologist, Dr. Neeraj Bhatt, as the director of today's OSMOSIS, Dr. Vandana Joshi, Dr. Jai Kumar Patil, Dr. Akash D. Patel, and many more names with us today. I really happy to announce today that this is this year this is the second osmosis. Last year we have conducted almost 15 osmosis pan India in the different regions. So now today we are running with the second osmosis. Very good evening to all of you. I welcome all our panel members and the moderators and our program director Dr. Neeraj Jain to this program, and I also welcome Dr. Sanjay Kamble sir, who is the medical head of Samarth, the entire as a company. So I welcome Dr. Sanjay Kamble sir for your introductions. Thank you.
So thank you, Saurav, and again I welcome everyone for today's meeting. Yet another osmosis, as Saurav has rightly said. Last year we had a lot of osmosis. This is the second one for this financial year, I suppose, and we have got a very good response from the medical fraternity about this particular scientific activity, and that really helps us. That really motivates us to have many such more programs. And as we already been into the therapy of prostate cancer, so we have today's topic about how one can treat prostate cancer, the castration resistant one, and the another panel discussion would be on the castration sensitive prostate cancer. So for this let me have the privilege to introduce our panelists, our moderators, and the program directors for the today's meeting. So the first panel discussion would be on the castration-resistant prostate cancer. How do I treat today? And for that, I welcome Dr. Neeraj Bhatt, sir. So, sir is a consultant medical oncologist and hemato-oncologist at Vadodara. And the other panel members we have for this particular discussion would be Dr. Vandana Joshi, who is a consultant medical oncology, Hope Rheumatology and Hemato-Oncology Clinic, Ahmedabad. Dr. Jai Kumar Patel, consultant medical oncology, Oncowell Cancer Hospital, Ahmedabad. Dr. Akash D. Patel, consultant medical oncology, Oncowell Cancer Hospital, Ahmedabad, for the today's discussion. So, Saurav, should we also invite a second panel, or we should be waiting for them to join? Okay, so we can have the second panel.
We should start with the first panel. Okay. In case any panel members are yet to join, they will join. I'll update you in between. So I request the organizer kindly run the slides for Dr. Neeraj Jain in the background. So with the permission of Dr. Neeraj Jain, I welcome Dr. Neeraj Jain, the consultant medical oncology, hemato-oncology clinic of Vadodara, as a program director. Thank you, sir. Over to you.
So, good evening, everyone. At the outset, I thank Samarth Onco for having me to moderate this session and inviting me to be a program director for this webinar. So, thank you very much. And I welcome all my panelists. I hope Dr. Vandana Joshi, Dr. Jai Kumar Patel, Dr. Akash Patel, Dr. Priyanka, Dr. Siddharth, and Dr. Rushit all are aboard or probably may join in a short period. Since I'm traveling, I've requested the concerned authority to share the PPT on my behalf. So with this, let's start discussion. As we all know, almost 80% of prostate cancer patients, by the time they are diagnosed in stage 4. And it would not be an overstatement to say that majority of this patient would experience the phase of castration resistance, because once the castration sensitive phase will get over and they'll enter the castration resistance phase, there are limited treatment options, and this has been the sort of topic of invention for majority of scientists, and majority of inventions are being taking place in this, because as far as or as long as the case remains castration sensitive, the treatment would remain androgen deprivation therapy. But post androgen deprivation therapy, when there is disease progression, treatment options are limited, and this is where the unmet need is, and this basically is the point of discussion for today. So obviously, castration resistance does not mean it would be a metastatic disease. It may present as localized disease, or it may be a metastatic disease. So with this, I would like to take the feedback of my panelist. I may start with, if I may start with Dr. Vandana Joshi, as to what are the factors that you take into account when you encounter castration-resistant prostate cancer, especially non-metastatic or localized castration-resistant prostate cancer? How do you look at it, and how do you manage those cases? Is Dr. Vandana there?
Yes, sir. I'm also traveling, so I was having issue in listening. Can you repeat the question, please, sir?
Yeah, so how do you manage non-metastatic castrate-resistant cases, or what are the factors you take into account, or do you treat all cases of castration, localized castration-resistant prostate cancers?
Sir, first I would like to check at the clinical scenario. What is the age of the patient? What is the extent of the disease? Whether it was initially operated or not, or presented with recurrence or not. So I would would like to look at the multiple factors.
So do you take prostate PSA doubling time into account, Dr. Vandana, or that doesn't carry any significance?
No, definitely, sir. PSA doubling time is important. To consider disease as a progression, we should consider this.
Yeah, fine. So next slide. Yes. So for localized non-metastatic CRPC, the first thing that we look into is PSA doubling time. And if PSA doubling time is more than 10 months, that means that the disease biology is indolent, and if patients are symptomatic, observation would remain as one of the treatment options or a major treatment options. But if PSA doubling time is less than 10 months, then this patient certainly would require treatment, because more often than not, they would become symptomatic in a short span of time. And the treatment options would include androgen receptor pathway inhibitors, be it apalutamide, darolutamide, enzalutamide, and other treatment options, which includes abiraterone. Although abiraterone does not have regulatory approval for M0 CRPC, but based on the data, data can be extrapolated, and it does remain a viable treatment option. Next slide. So if you look at the metastasis-free survival in various studies like PROSPER, ARAMIS, and SPARTAN, they certainly show that there is improvement in the overall survival as well as progression-free survival when it is compared with placebo. The HR hazard ratio that are seen in various studies range from 0.41 to 0.48. That means there is around 60 to 70% benefit in terms of improvement in PFS and OS as far as use of these newer anti-androgens are concerned when they are compared with placebo. Next slide. Next slide, please. Am I audible?
Yes, sir, you are audible. Nirav, can we have the next slide, please?
Yes. So the overall survival data for 3 large randomized controlled trials underscore the need for early treatment for men with non-metastatic CRPC. And here the comparison is in ARAMIS, it is darolutamide versus placebo. In SPARTAN, it's apalutamide versus placebo. And in PROSPER, it is ENZA versus placebo. And here HR hazard ratio, as we can see, are 0.69, 0.78, and 0.73, which are quite robust. And the median overall survival that were achieved where they were not reached in darolutamide, that is RMS study, while they were 73 versus 59 in Spartan and 67 versus 56 in Prosper study. Next slide. So these are the therapies currently available to treat metastatic CRPC. Sipuleucel-T is a low dose or low intensity immunotherapy when the disease biology is low grade, low volume disease and patients has minimal symptoms, then Sipuleucel-T can be considered. Androgen receptor pathway inhibitors like enzalutamide, apalutamide, darolutamide are first-line treatment options. Androgen biosynthesis inhibitor abiraterone can be considered. Docetaxel, cabazitaxel are chemotherapy options to treat CRPC. Radium-223 is a bone-seeking alpha-emitting particle, which is useful for palliation of symptoms, especially painful bone metastasis. And other treatment options would include PARP inhibitors for those who are HRR deficient or immunotherapy, which are MSI high. So these are the current treatment options from where we have to choose the appropriate options for CRPC cases. Next slide. Next slide, please. Yes. So this is the outline under which this discussion will proceed. It is the selection of first line and second line treatment options, how to sequence various treatment options amongst the available therapies, that is androgen receptor pathway inhibitors versus abiraterone versus chemo and other minor treatment options, and what is the role of emerging targeted therapy. Next slide. So first line treatment option would obviously depend on the type of treatment that was given for when patient was in hormone sensitive phase, and the currently the treatment options which are approved for castration sensitive prostate cancer apart from androgen deprivation therapy is docetaxel, especially for high volume bone or visceral metastasis, abiraterone, as well as RPs, that is androgen receptor pathway inhibitors. So based on the treatment that patient has received in castration sensitive phase, that we can decide the treatment options for CRPC. Next slide. So with this background, let's start the case-based discussion. The first case in question is a case of 62-year-old male patient, non-diabetic, hypertensive, CA prostate diagnosed in March 18, Gleason score 9, PSA 545, extensive bone and nodal metastasis. Patient was started with androgen deprivation therapy alone in April 18, with nadir achieved in of 1.9 in July 18. Somehow he became symptomatic for bone metastasis, bone pain, and progressed and achieved CRPC phase in November. So it was hardly 6 months of castration sensitive phase before patient became castration resistance. PSS started increasing and it was 93. So, Dr. Jai, how do you look at it, this scenario? And given the choice, how would you have managed this castration-sensitive phase? Would you have been comfortable treating this case only with androgen deprivation therapy, or would you have been comfortable add other treatment apart from ADT? Is Dr. Jai there?
Jaikumar is there?
Dr.
No,
Dr.
I don't
Akash,
think Dr. Jaikumar sir
yeah.
is there. Yeah.
If Akash can take this question.
Yes, sir. So in this case, the PSA doubling time is less than 10 months here, even after the patient is on the ADT already. So and the patient is non-diabetic, non-hypertensive. So we can easily put this patient on our novel hormone treatment, that is abiraterone plus prednisolone or the enzalutamide.
Akash, how would you have managed castration-sensitive phase is what I'm asking. This patient was only managed with androgen deprivation therapy, patient has extensive bone and nodal metastasis. So if you
Okay.
were to manage this case, how would you have proceeded forward for hormone sensitive phase?
Okay, so initially on the day of the diagnosis, I generally recommend in my patient to undergo the orchidectomy. And if the patient is not willing for surgical castration, then I will go for the relugolix or the luprolide for the ADT of the patient.
Yeah. So would you have been comfortable or would you
And
have preferred adding chemotherapy to this phase and apart
no,
from androgen deprivation therapy?
No, sir. We'll proceed with only this ADT, and we'll likely would like to have add zoledronic acid or denosumab, because
Yeah.
the patient carries the extensive bony metastasis. But again, I would like to know about the site of the bone metastasis, which involves the beyond vertebral body or pelvis or not.
And Dr.
Because here,
Priyanka, do you agree with the opinion of Dr. Akash? Is Dr. Priyanka there? Dr. Siddharth?
Good evening, sir.
Yeah, good
Sir,
evening.
in the phase with the metastatic HSPC phase with extensive bone and nodal metastasis, I would usually prefer to give something additional to ADT, because
Yeah.
at least even in a low tumor burden disease, we should be adding something like abiraterone or enzalutamide. We can even go for triple drug therapy if there is a high burden disease.
So if we
Usually,
go by the chartered and stamped data, it says that for extensive bone metastasis extending beyond pelvis or high volume bone metastasis or visceral metastasis, there is role of using docetaxel. Probably it improves the
yes, sir.
overall survival and PFS. So one
Yes, sir.
can consider apart because this patient was treated only with ADT. Probably because of high volume metastasis, he might have recurred early. You never know. But anyway, coming back to our discussion, patient again becomes symptomatic with achievement of CRPC. Patient's PSA is 93 and the castration sensitive phase was less than 1 year. So how would you take this case forward from here onwards? Next slide, please.
Sir,
Siddharth.
yes, sir. Sir,
Ah,
since the PSA doubling time is very well less than 10 months or 1 year, we would consider it to be a high risk disease.
yeah.
In such patients, we should go for imaging to ensure that the metastasis have increased or the disease has increased. And
So this is the
since it is,
PSMS scan, which shows there is extensive metastasis. Almost all bones or vertebra, sternum have been involved. So what should be the preferred treatment option? Should it be chemo or androgen receptor pathway inhibitor or androgen biosynthesis inhibitor?
sir, in high risk diseases like this, I would prefer to go for docetaxel, and which is rightly recommended option.
Next slide.
Uh,
Yeah. So docetaxel is the recommended treatment option at this point of time. Yeah. So it is the recommended treatment option. If you look at the text data, where docetaxel plus prednisolone was compared to mitoxantrone plus prednisolone. Next slide. Here it can be seen that there was significant improvement in progression-free survival as well as overall survival, especially in 3-weekly docetaxel arm. Weekly docetaxel arm was numerically superior but statistically not significant compared to mitoxantrone, but 3-weekly docetaxel was certainly superior with significant p-value. Next slide. Coming to second case scenario, this case is quite different from the case we discussed first. He is 88 years, multiple comorbidities. He was diagnosed with CA prostate in July 17. PSA was 2,700 plus, Gleason score 8, nodal as well as bone metastasis, and patient was started on medical castration, Degarelix, with nadir achieved of 33, maybe in an year's time. However, patient achieved CRPC in August 18 with rising PSA, that is 82. Patient has type 2 diabetes, hypertension, coronary artery disease, ejection fraction is 40%, and NYHA grade 2 breathing difficulty. So multiple comorbidities, diabetes, hypertension, advanced age, high PSA, high volume disease, and early achievement of CRPC maybe in a year's time. So what should be the further course of action? Dr. Rashid, if you can take this.
Yes, sir. So in this patient is also, I would consider high risk recurrence in a short time. Now CRPC and nodal with skeletal mets. With all this comorbidity and PS2, probably is not a candidate for chemotherapy. At this
Next slide.
point,
Yeah.
we
Yeah, carry
consider
on,
the
please.
HRR testing on the biopsy block. And if biopsy, that is the best, CRPC. And after HRR testing is available, if something is positive like BRCA, I would like to go with olaparib with abiraterone in spite of this comorbidities. Otherwise, I would go for enzalutamide.
Yeah. So, Rushit, when would you advise this HRR and MSI in prostate malignancy cases? For example, during ovary or breast, we usually advise at the start of treatment. Do you practice the same in prostate malignancy, or do you wait for for someone to achieve CRPC state before you prescribe these investigations?
So, sir, I do suggest upfront only for all my patients, but most of them are, I would say, they end up doing it later at a later date, maybe at a CRPC state. But I emphasize more whenever it has become CRPC at least.
Dr. Vandana, what is your opinion or what is your practice?
Sir, I also recommended doing HRR testing with MSI status at upfront in metastatic CRPC.
But if you look at the incidence of mutations or HRR mutations in prostate malignancy, unlike breast or ovary, where germline mutations are very common, with progressive disease in prostate malignancy, the incidence of HRR mutations is highest in CRPC state, not in castration-sensitive stage. See, it is almost 11% in CSPC, that is castration-sensitive phase, but 25%, it increases up to 25% in castration resistant stage, and it is mainly because of somatic mutations. So almost 1 out of 4 patient who is diagnosed with CRPC will have genetic mutations compared to 1 out of 10 patients when the cancer would be in castration sensitive phase. So would that deter you from offering upfront germline mutation test for prostate malignancy? Dr. Akash, what is your opinion?
Yes, sir. Actually, we should do the somatic mutation testing in all the cases of metastatic prostate cancer patient rather than only germline. Because as you rightly said that the incidence of this mutation is high with the when the patient getting the CRPC state. So here I
Next
would
slide. Yeah.
here I would suggest that in this patient with who has 88 year of age with multiple comorbidity and with the life expectancy less than 5 years, we can only we should only start with only enzalutamide and may add according to the HRR pathway or somatic mutation panel.
Yeah, fine. So this is the PREVAIL study which compared enzalutamide to placebo, and this is after progression to CRPC state. Next slide. And here we can see that both radiographic PFS as well as median overall survival were better in enzalutamide arm compared to placebo arm. So much so that the HR for radiographic PFS is only 18%. That means there are more than 80% chances that enzalutamide improves radiographic PFS compared to placebo. The difference in the median survival is not that great. However, HR is 0.7, which is significant. Next slide. Next. Yes. Same stands true for abiraterone, which is proven in COW AA302 study. This is post-progression in CRPC state. So progressive chemo-naive patient in CRPC were enrolled to abiraterone acetate 1000 milligram plus placebo versus placebo plus prednisolone. And the efficacy endpoints were radiographic PFS and overall survival with a few more secondary endpoints. Next slide. And here we can see that there is strong trend in overall survival as primary endpoint. Overall survival at 30 months was not reached in abiraterone acetate arm versus it was 27 months in placebo arm, achieving an HR of 0.7. P-value was obviously significant, that is 0.009. Radiographic PFS was 8 versus 16 months and OS was 30 versus 35 months in favor of experimental arm of abiraterone. Next slide. So how to select the second line treatment for metastatic CRPC? Next. So coming back to case one, which was a relatively young patient with no comorbidities, and patient was started with docetaxel post progression on androgen deprivation therapy. Patient received 4 cycles of docetaxel. There were increase in the bone pain. PSMA PET scan showed increase in disease, increase in the progression like skeletal metastasis, and there was also rise in PSA. So we can say that patient had short-lasting response to docetaxel-based therapy. Next slide. And this is the PET scan post docetaxel. So what should be the next line of treatment? Dr. Siddharth, if you can take this question. Would you consider cabazitaxel or would you put this patient on abiraterone or enzalutamide? This is post docetaxel. Or you have anything else to offer?
Sir, if PSA progression is not very high or PSA is not significantly increased, we may think in terms of neuroendocrine transformation. The second thing is that we can opt for either of the 3 agents. Abiraterone followed by enzalutamide can be an option, but I would rather go for abiraterone because the patient had some cardiac symptoms, and cabazitaxel can also be an option if there is a high disease burden, provided we are very sure of the toxicity, means tolerance of toxicity by the patient.
Yeah.
Either of 3 can be chosen.
So it is individualized approach, but we can say that there is short-lasting response to docetaxel and there is fast progression on docetaxel. So if you look at the biology of disease, this patient is unlikely to respond well to either of these treatment. And maybe given the choice, lutetium PSMA therapy might turn better treatment options compared to all these 3. But anyway, there is a point of discussion. Next slide. Yeah. So this is the tropic study which compared cabazitaxel versus mitoxantrone in CRPC post progression on docetaxel. Cabazitaxel was given in the dose of 25 milligrams per meter square, mitoxantrone in conventional dose. Next slide. And we can see that there was improvement in median overall survival 15 months versus 12.7 months, achieving HR of 0.7 and p-value of less than 0.0001. So cabazitaxel certainly was better at improving the overall survival compared to Oncotron. Next slide. Similarly, this is abiraterone. This is post-progression on docetaxel. Arms were same as the initial 302 study. Next slide. Here we can see that abiraterone achieved overall survival of 14.8 months versus 10.9 months in placebo. Significant improvement in overall survival, as well as subgroup analysis showed that pain palliation was good. Whether patients were treated with 1 regimen or 2 regimen, and progression type was only biochemical failure, radiographic progression, or visceral disease. All these subgroups were benefited by using abiraterone compared to placebo. Next slide. AFM study is that of enzalutamide in post-docetaxel scenario. It was compared to placebo. Next slide. Just like TROPIC and COW 301 study, AFM also showed improvement in progression, PFS as well as overall survival. 18 months versus 13 months, significant HR of 0.63. Next slide. So we can say that any of this, cabazitaxel, abiraterone, or enzalutamide, all three drugs were superior compared to placebo. It remains individual's preference of clinician what to offer based on the clinical scenario. Now coming to case 2, was elderly, had multiple comorbidities, was treated with initially with androgen deprivation therapy, later turned CRPC in a short span of time, and was offered androgen receptor pathway inhibitor because of poor performance status. And again, on enzalutamide, patient has had disease progression with PSA of 1,763. So, Dr. Vandana, how would you take this case forward? Next slide. This is the post enzalutamide PET scan, PSMA PET scan. There is significant disease progression. So, can we offer chemotherapy, or we should continue with androgen receptor based therapy as second line treatment? Is Dr. Vandana
Dr.
there?
Neeraj, I'm sorry to interfere. Dr. Priyanka is already there. You can ask, I think, if
Yeah,
she's available.
Priyanka, if you have heard this question, you can take this.
Yes, yes. Hello. Actually, so this 88-year-old gentleman progressing on first line treatment, I think we can consider hormonal based treatment in the form of abiraterone or enzalutamide in this part, because chemotherapy at the age of 88, I would say, is very difficult.
Yeah, the scenario is, Priyanka, patient was initially treated only with androgen deprivation therapy, had progression, achieved CRPC, and in CRPC phase, he was offered enzalutamide. And on
Yes.
enzalutamide, he has progression now.
So I think then we can go for supportive care, and versatile lutetium-based therapy that we can offer.
Yeah.
That in this
Fine. So
particular,
it would be a
because of
sort
the
of
age of 18.
individualized treatment option rather than
Yes,
strictly
but
following the
I would be very
guidelines.
skeptical in giving chemotherapy in such kind of patients,
Yeah.
looking at the biology of disease and age of the patient.
So Siddharth, do you agree with the opinion of Dr. Priyanka, or you have something different to offer?
Sir, I very much agree to madam, because sequential enzalutamide followed by abiraterone or abiraterone followed by enzalutamide does not give very good response. And lutetium, we see if the patient is otherwise fit, lutetium does give a good response if given for full number of cycles, maybe 4 to 6 cycles. It is the best option if we actually want to go for therapy. And just in case we don't want to go for therapy, supportive care would be the other choice.
So next slide. How do we sequence the various agents? Is there any optimal sequence of life expectancy extending therapies? Next slide. So coming to this question, when a patient has been treated with androgen receptor pathway inhibitor or androgen biosynthesis inhibitor, that means abiraterone and enzalutamide, and the sequence is then flipped, whether enzalutamide is followed by abiraterone or abiraterone is followed by enzalutamide, there are very less chances that this patient would respond in a way that we are expecting compared to the side effect that we would offer by offering this treatment. So PSA fall of more than 50% is seen in hardly 8% of patient as per the study when enzalutamide is being followed by abiraterone, and in around 20-30% of patient when initially patient is being treated with abiraterone and then shifted to enzalutamide. So putting the patient on androgen receptor pathway inhibitors or androgen receptor based therapy is unlikely to achieve good response, especially in CRPC patient, especially when they have already been treated with one androgen receptor based therapy. Next slide. So this study echoes the similar findings that the curve is the worst when androgen receptor therapy is being followed by similar androgen receptor therapy, just the molecule is different compared to when chemo is replaced by androgen receptor pathway inhibitors or ARPIs are being replaced by chemotherapy. Next. Next slide. So this is regarding lutetium PSMA based therapy. Next. This is Vision study wherein lutetium PSMA based therapy, especially when these patients were treated with androgen receptor pathway inhibitors or abiraterone or 1 to 2 taxane based chemotherapy, were then subsequently challenged by lutetium PSMA based therapy. Patients were treated with lutetium PSA once in 6 weeks for 4 to 6 cycles, and they were compared to or staked against protocol permitted SOC, which actually excluded using immunotherapy or radium-based therapy. Next slide. Here it can be seen that there is completely different, these curves are absolutely not overlapping, they are separate. And there is significant improvement in overall survival as well as PSA by using lutetium PSMA based therapy, achieving HR of 0.62. That means there were 38% reduction in the risk of death by using PSMA based therapy, especially when they are compared to standard of care therapy. Next slide. So, Dr. Rushid, do you agree, or what is the place of lutetium PSMA therapy in your clinical practice? Where do you prefer to use post docetaxel, post cabazitaxel, or anywhere else?
In my practice currently, I suggest patients post docetaxel and post hormonal treatment most of the time. Yeah, it is 2 prior therapy.
I think in pre-docetaxel era, it doesn't have regulatory approval, so we can only use it in post-docetaxel case because one of the studies have shown that it fares better compared to cabazitaxel. Fine. There are various targeted therapies available, especially for those who express actionable mutation, especially DNA damage response pathways or those who are MSI high. Next slide. So these are the mutations in DNA repair pathways. Single stranded mutations are being repaired by base excision repair. Bulky edits are being repaired by nucleotide excision. Base mismatches are obviously repaired by mismatch repair genes, but double-stranded DNA breaks are being repaired by either non-homologous end joining, which is less efficient mechanism, and HRR, homologous recombinant repair, which is the robust mechanism. And this is where the PARP inhibitors come into the picture. Next slide. And as we discussed, the incidence of germline mutations in genes mediating DNA repair processes in metastatic prostate cancer is around 11.8%, especially when the patient is in castration-sensitive phase. Next slide. But when it achieves castration resistance phase, it increases to as high as almost 24%. Next slide. And this is where the role of PARP inhibitors comes. And this was based on the PROfound trial, which enrolled those patients who had HRR deficiency and had previously been treated with androgen receptor pathway inhibitors as or chemotherapy. Next slide. This basically were divided in 2 cohorts. One comprised of BRCA1, 2 or ATM, and other had other HRR mutated genes, and they were subjected to olaparib versus placebo or physician's choice of treatment. Next slide. Here it can be seen that patient who had BRCA1, BRCA2 mutation or ATM mutation significantly improved the radiological PFS. And when the results of cohort A and cohort B were combined, that also fared better compared to the physician's choice of treatment. However, apart from BRCA1, BRCA2 or ATM, when other HRR genes were mutated, their improvement was numerically better, but statistically not significant. So that part was not considered. Next slide. Similarly, MMR mutations are seen in around 3 to 5% patients of metastatic CRPC. Next. And here it can be seen that in Keynote 016 study, where MSI high patients were taken, which included periampullary cholangiocarcinoma, colorectal malignancies, endometrial, gastroesophageal, neuroendocrine, osteosarcomas, to name a few. One of them was prostate malignancies, and they improved overall progression-free survival. There was not much improvement in the overall survival. PFS was improved, rather, radiographic PFS. Next slide. So these are the current treatment options available for treating metastatic castration-resistant prostate cancer. It depends on what treatment patient has been given in castration-sensitive phase. If patient has not been treated with docetaxel or receptor pathways, then any of the treatment can be offered depending on the clinical scenario. If patient has been treated with hormonal therapy but no docetaxel, then chemotherapy should be the way to go. If chemotherapy has been given, hormonal treatment has not been given, again, then abiraterone, cabazitaxel, enzalutamide can be selected based on the clinician's discretion. And if all the treatment has been given, again, then the treatment should be individualized, and those who are showing actionable mutation should be treated accordingly. Next slide. So take-home message is when patient has been treated or in castration-resistant prostate cancer is significant, majority of the patient would enter CRPC phase because 80% are diagnosed in stage 4, and the treatment option would revolve around the treatment that they have been treated in hormone-sensitive phase, and treatment options would include androgen receptor pathway inhibitors, androgen biosynthesis inhibitors, chemotherapy, actionable mutations like HRR based therapy. MSI high patients may be treated with Keytruda, and those who do not respond to chemotherapy or androgen receptor pathway inhibitors may be tried with lutetium PSMA based therapy. Next slide. So these are the current treatment options available. The scenario is still evolving, and maybe in near future we might see other treatment options which might help improve the survival for castration-resistant prostate cancer patients. Next slide. With this, I thank all my panelists for giving their feedbacks, and I hand over the platform to the organizers. Thank you very much.
Thank you, Dr. Neeraj Bhatt. Such a comprehensive and crisp presentations, and thanks to all our panelists, Dr. Vandana Joshi, Dr. Akash D. Patel, Dr. Priyanka Patel, Dr. Siddharth Lat, and Dr. Rusit Shah. So with that, I welcome Dr. Akash Tiwari, Consultant Medical Oncology, Robert Nursing Home, and RC Indore. So I would like to also welcome to the other panelists who is already there, Dr. Anup Mantri sir, Dr. Rajesh Patidar sir, Dr. Vikas Asati sir, Dr. Rakesh Kumar Misra, and Dr. Sadvik. So with that, I would like to take it over to Dr. Akash Tiwari sir to take the sessions for the second panel.
Hi, friends. So it is always a pleasure to be amongst friends, and we have a lot on the panel. What we have today in terms of discussion, are my slides visible?
Yes, sir, it is visible, sir.
Thank you. Thank you. So what we have in discussion today is this data on or this evidence of practice on castrate-resistant prostate cancer. Castrate-sensitive prostate cancer. And the general background of the discussion would be that we would discuss the modes of action of GnRH agonists versus antagonists, and what consideration do our colleagues take when choosing one. Then how do they manage the non-metastatic castrate-sensitive prostate cancer? the oligometastatic castrate-sensitive prostate cancer and the role of RT in the routine practice, and then the routine bread and butter part of the metastatic CSPCs. And if they are practicing a doublet versus a triplet combination. Do I have everyone? Dr. Rajesh?
Yes, Dr. Akash.
Hi. Thank you. So, just as a starter, so we get broadly two types of patients in our practice. The largest chunk are those of patients who have been diagnosed de novo as metastatic carcinoma of prostate. And then there are these patients, a minority of them, albeit in my practice, who have been diagnosed as localized advanced prostate cancer, and post a definitive therapy, they progress. So, and though there was this dictum earlier that medical oncologists would handle the castrate sensitive or the resistant part and the urologist vice versa. But increasingly in our practice, a lot of patients tend to meet the oncologist upfront with the standard definitions and the role that Huggins played in finding out the role of castration or androgen deprivation in the treatment of castrate-resistant prostate cancer. We move ahead. So I'll take it from Dr. Vikas. So Vikas sir, what is the mainstay of ADT in your practice, and based on what factors do you choose? Surgical versus medical first, and then we'll take things from there, sir.
So I think to divide between surgical and medical, it is around 50-50 for me. So, surgical castration is, one day treatment, while if you go for medical treatment, it is lifelong. So, around half of my patient may not be ready either due to their own wish or either due to their pocket. So, around 50% of my patient still choose to go for surgical castration, and remaining 50% will go for medical. So, this is my usual practice.
Dr. Rakesh, your personal choice in surgical versus medical castration, of course, as Vikas sir mentioned, there are other factors to it, and why?
So in the metastatic setting, what Dr. Akash, I usually do prefer to go for the surgical castration in a patient who are having, I think that they have a follow-up issue. In a good educated patient, I usually go with the medical castration if they want. But most of the time, in a patient who are having the Aishman, where in the Aishman, we actually do not get these medical castration. So these usually we go for the surgical castration in Aishman patients. Sir.
I think in Ayushman we have a Leuprolide,
Sir,
22.5 every 3 months.
We do have.
so in Chhattisgarh, usually we do we do not have.
Maybe in the Raipur, I don't know, but we are giving Leuprolide.
So that's good, sir. Actually, you have the option of using that one, sir. So I think, sir, Dr. Akash had some connection issue, I think.
Yes. I think we should wait. Yeah.
So Vikas, sir.
Yeah, he joined.
We can discuss the questions, sir.
Yeah. So I think he has joined.
Do it in my absence.
Yes.
So sorry for the unstable relation. So yes, in my practice too, I offer patient surgical castration, but the upfront uptake of this opinion is very less in my practice. So Satvik, a GnRH agonist and antagonist, what do you choose, and based on surgical castration options?
So apart from impending spinal cord compression, which is, I think it hardly we see. So most of the times patients have stable metastasis, bony metastasis. So we can go either way. So then I choose Leuprolide if I'm going for medical castration. But obviously, if there is an impending spinal cord compression, then I go for GnRH antagonist or surgical castration if the patient is willing.
Rajesh, sir, your view, and if an antagonist, oral versus IV, so this also, man, how much is actually regularly good?
Your voice is breaking. I think again Akash is gone. So in my practice, what I am doing is I advise patient for surgical orchidectomy if he is willing, because one that will be pocket friendly for lifelong. And if patient is not willing for surgical orchidectomy, then if patient is in a crisis, then I use Degarelix. If patient is not crisis, then either of these can be used. Most of the time, I end up using leuprolide, and the most of the time I am giving 3 monthly. Though monthly data is, I think it is better.
So, Dr. Rajesh, have you like what is your experience with the Relucolex now? It is available.
Yeah,
Have
it's
you used?
available. I have not yet used it. I think I'm concerned about the compliance, and most of the time I end up using a sub IM leuprolide only.
Anup, your take, surgical, medical versus, and in medical, oral versus IM.
So, sir,
Is Anup okay?
I also advise for surgical castration because there's no compliance issue. But if the patient is having some issues for orchidectomy, if he's not willing, then I go for GnRH agonist, mostly leuprolide, until unless patient is in impending compression. Relugolix I don't give because I in fear of some compliance issue whether patient will take it regularly or not.
So, so if I could summarize the view of the house, essentially surgical castration or medical castration, and I also concur with it. In terms of the usage of GnRH agonist versus antagonist, I think it is essentially driven here by the fear of the flare rather than anything else. In my practice, I've almost entirely shifted to GnRH antagonist oral. Um, Especially in patients who have CVA risk. So, Vikas sir, do you take this CVA risk into consideration when you are
So,
using your drugs?
I think severe risk is
And how
important.
significant is it?
Yeah, so I think it is important, the cardiovascular risk, and especially when we are giving abiraterone. So, the abiraterone in itself has cardiovascular risk, and when we are giving with agonist, it's quadruple the risk. So, I also agree with that. For last 6 months, I also have shifted to antagonist, the oral antagonist. The generics are available. For last 6 months, majority of my patients are receiving Relugolix, and the testosterone level that I have checking at least for couple of months, it is well below the castrate level. But the only problem that the compliance, we need to choose our patient and we need to counsel our patient that even if you stop the drug for 2 to 3 days or a week, the testosterone level can jump. So like this is that.
That's again. So, sir, as you bring out this point of monitoring, I'll take it, Rajesh sir, and then Dr. Rakesh. What tests do you offer to your patients in your follow-up, especially if they are on medical management routinely? Rajesh sir, you can take it, and then Dr. Rakesh.
So you are asking me how I manage, how I test whether patient is
How do you
undergoing.
follow these patients? Well, what are routine tests that you do for, say I had metastatic castrate-sensitive prostate cancer in your follow-up? Sir, what were the investigation you would offer? And
So I do, if patient is on, I look for the castration at least at 3 months, and then at 3 monthly I look for testosterone if patient is on medical castration. And PSA level also initially first 3 months I don't do, but after 3 months I regularly, at least 3 monthly I do PSA also, or whenever patient comes. If patient is in oral tablets, like at least 2 to 3 month PSA, 3 monthly PSA, and 3 monthly castration testosterone level I check.
great, Dr. Rakesh, anything that you would have to add?
Almost same, sir. I do test serum testosterone after if I am going for the medical castration after the 3 months. PSA every 3 months. Apart from this, I do go with the routine blood testing, sometimes CBC, LFT, RFTs, and the calcium usually I do to always do whenever I do patient come for the follow-up. I always check for the calcium, bone mineral density at the first if patient in old age patients, sir.
Bone mineral density. So, Satvik, as we move forward, so what we could conclude is that surgical castration for both, medical castration, some are going for CVA risk-based oral antagonists versus agonists, and testosterone testing and regular PSA with bone density is a must that people are doing. So, Satvik, so we get these patients who have had radical prostatectomy or a radical RT, and then their PSA starts rising. How do you manage these patients in your practice?
So obviously, if I have a only rising PSA patient, then I look for symptoms, and apart from that, first of all, if the patient, I'll check for the the castrate levels. If the patient was on leuprolide, and also I would do imaging if the PSA is rising.
So, Satvik, what imaging do you think would be the best to do in these patients, and at what PSA level? So, will the threshold or regular monitoring?
So doubling of PSA.
What imaging at what PSA threshold?
So doubling of PSA is what is defined as PSA failure as per the criteria, and I would go for PSMA PET in rising PSA.
Anu, which of these patients would you treat? So, would you treat a biochemical failure? Would you wait for the disease to relapse? How would you do it in your practice?
I generally wait for.
Anup bhai?
I generally, sir, do not treat patients for just biochemical relapse. I do wait for if there is any symptoms or if there is metastasis.
So, do you also do a PSMA PET for all these patients, and then even if there is one lesion, you treat them, or how do you manage? So, is there symptomatic MET versus any MET on a scan?
It's a symptomatic metastasis, or if patient has.
Patidar sir, your view on it?
If patient is having rising PSA, and if I did PSA PET scan, even the asymptomatic metastasis is there, I will intend to treat the patient. If on bone, I can found on some lesion in the PSA PET scan, then I will treat the patient.
So we know that there are certain subgroup of patients who are high risk. The patients who have had a doubling down in less than 1 year, who have higher with a higher Gleason score, who are on ADT plus Enza or any other agent and subsequently have relapsed. Vikas sir, will your approach be different for these patients? So suppose this patient, say, post a radical prostatectomy, relapses within a year with a PSA doubling time of say 9 months or 6 months. Would you, if then these patients do not have a disease on scan, would your approach change?
Yeah, so we have a data for abiraterone, enzalutamide, and also for darolutamide that if that PSA doublet time is less, this patient can be offered the novel agents, and there is a progression-free survival. And I would like to just clarify one thing, that when it comes to the prostate cancer and when we ask for PFS, not only the disease progression, even PSA progression is also considered as an event. So, like the concept the of C ovary, where we usually wait for to rise in C125 to start the treatment. The same thing may not be applicable for prostate, and we know how the CRPC, it's a lethal disease. So if PSA is showing some disease, I also would like to start the treatment.
Dr. Satwik, your view on intermittent versus continuous ADT, both non-metastatic, metastatic setup. You can take either of it first.
So I don't practice and I don't prefer intermittent ADT. I only give continuous ADT in a rare possibility where patient is having severe ADT related side effects. There we can try, but practically I have never tried intermittent ADT.
Great. Anup, your take on it, interval versus continuous ADT. Do you offer interval ADT in your practice? And we'll come to Rajesh sir for why this practice is such.
No, sir, never practiced.
So I am very sure. Does somebody practice intermittent ADT?
No, Akash bhai, no, I no one
Rajesh sir,
practice, but sometime patient itself convert into
So,
it into intermittent.
so
So I
So-
think the intermittent
Rajesh sir, I'm wondering-
ADT is a side effect of medical castration.
Yes. No, so it is.
medical cash. I would. So sir, we know that there is evidence that the disease specific survival does not change in intermittent versus continuous ADT, and I will also agree that I never offer intermittent ADT to our patient. Rajesh sir, why do you think that there's this limited acceptance amongst medical oncologists for offering intermittent ADT? Vikas sir or Rajesh sir, either you can take it.
So I think the inherent fear of progression and seeing so many CRPC patient dying, I think we are hesitant. We don't want to take the risk. Like, this is my thought.
I agree. Sometimes I feel that these patients would default and then come back. So there is data of comparison between relugolix and leuprolide. There's just two things that I like to point out, and our colleagues had pointed out most of it. The one is that the sustained rate of castration was comparable, maybe slightly higher in relugolix. But the interesting thing is not the fall of the testosterone. So we know that there is a flare when we have given leuprolide. But as Dr. Vikas was pointing out, once we stop the relugolix, the jump is sharp and immediate in terms of testosterone rise, and that is something that concerns a lot of people in using of the drug. And the second thing is that undoubtedly the cardiac rate risk is lesser when you are using relugolix. And I think as was pointed out by the panel, carefully chosen patients, probably the oral pill might be a better option.
Akash, can you go to the previous slide, the previous one?
Sure, sir.
The last.
The last one. Sure.
So like this is important that in leuprolide, 88.8% patient, the castrate level was maintained, and relugolix 96.7. So it's not 100%. I think this is very important that we need to check for testosterone at least in initial 6 months. So
We should.
yeah, so checking for testosterone is very important because 5 out of 100 patients will not achieve castration even with antagonist, either degarelix or relugolix. And when we are in leuprolide, it is just 88. So means 12 out of 100 patients are not achieving the required testosterone. And for this patient, the option remains is the surgical castration.
So we know that there are issues with using of ADTs. So Satvik, in your practice, what are the common issues that people point out? What do you pick up in labs, and what is the common issue that people point out? And then we can come to Dr. Rakesh and how do you mitigate it in your practice?
So most of my patients who are on ADT complain of insomnia, fatigue. That is what I have seen, and most commonly these are the side effects. Cardiovascular, I have not seen, or maybe if I've come across, sometimes it gets unnoticed and unrelated. But yes, fatigue and insomnia is one which I very commonly see. Apart from the dyslipidemia, over long-term dyslipidemia is again one problem. And most of the time we are giving either for osteoporosis prevention in HSPC setting, we are giving zoledronic or denosumab. So most of the times I do not see osteoporosis, and I am not doing DEXA scan also routinely in these patients.
So are you routinely giving them zoledronic acid or denosumab?
6 monthly, yes.
When on ADT?
6 monthly, yes.
Yes. Anup, common toxicities that you see?
And I think it's the same toxicity, fatigueness, dyslipidemia, that I think not CV I have not encountered.
So, Dr. Rakesh, how do you mitigate them? And then I'll come to my experience on this.
So only thing which some patient I do see hot flashes. So that is something which actually, but after a proper counseling, I able to manage that. Most of the patient they able to continue the treatment. So it's not a problem. Regarding the dyslipidemia, it can be manageable. Yes, a few patients I have seen the cardiovascular events, but it could be because of their age-related factor. But yes, that also we need to be keen.
So I'll point out two things. My experience with CVAs have been bad. So at least 3-4 patients that I can recall of on leuprolide have had. And then a lot of my patients do complain of this sexual dysfunction that they are facing. But as pointed out, I also never offer them intermittent ADT in my practice. So coming to this oligometastatic castrate-sensitive prostate cancer, Rajesh sir, any specific change that you do in your practice if the patient is oligometastatic versus a widespread metastatic disease when you are treating them?
Patient is a oligometastatic
Rajesh
disease
sir?
and low, but yeah.
Oligometastatic.
So patient, yeah. So in this setting, I will consider to give RT if it is a low burden disease to the local prostate RT. Rest I will continue abiraterone or enzalutamide and ADT.
Does everybody in the house offer RT to these patients? And a yes would do with an open mic or a no. So
Yes.
we'll take the non-consenting voice.
Low volume metastatic, yes, prostate only.
And does the dose remain the same? Sorry, not
Yes, sir,
not
same.
our
We
domain.
can
Dose is the same.
I think dose is lesser as
No, I
compared to
think
the
it's
radical.
70 gray. I think it is same.
I think in this setting the dose is slightly lesser. I will check in.
So let us come to the most common encountered past, and as we moved rapidly, the metastatic castrate-sensitive prostate cancer. So I'll come to Anup upfront. Anup, how do you manage these patients in terms of your choice with the ADT? We have already discussed it at length. So the choice with the partner drug,
So, sir,
1, 2, and which drugs?
it will depend on the patient's age and performance status. It will depend on the disease volume. If I see patient is relatively fit and has good high volume disease, then I go with triplet therapy. That is abiraterone plus docetaxel. And if the patient is having little, I think if the patient is not relatively, if you say around 60 to 70 year and not that high volume disease, then my first preference, if I'm giving doublet, I prefer docetaxel because it has a finite duration of treatment, 6 cycles of chemotherapy. And if the patient is a little elderly, not fit for chemotherapy, then I go for abiraterone versus enzalutamide, depending on the patient comorbidity like cardiovascular event, diabetes, or whether having some neurological seizure disorder. That will depend on the whether I will give abiraterone and enzalutamide, like that.
So Anup, age, you said disease burden,
Performance
and
status.
comorbidity status. Right?
Yes, sir.
Catch you right. Satvik bhai, do you conform to a specific defined criteria of high burden disease, or it is just by the look of it? So do you actually categorize these patients as low risk, high risk, or you see the scan and you make a call? How do you do it
I
actually
do.
in your practice?
Yeah, so I do see the scan and classify according to the criteria, but most of the time it's either obviously high volume disease or it's obviously low volume. Borderline cases where I have to count the mets, it is rarely seen that there are 3 mets or 4 mets. It's rarely seen. Either it's only nodal metastasis or a single bone mets. That is obviously a low volume disease, and if it's a high volume, then it's mostly a florid metastasis, bone metastasis.
So a lot of time we see these patients with multiple vertebral plus pelvic mets, a Gleason score of 8. But Anup pointed out a lot of patients we give them docetaxel, but essentially don't categorize for high risk based on that trial. So that's why, so Vikas sir, your choice on it. As Satvik pointed out, mostly if looks high risk, it is high risk, or do you actually sit and count and classify?
So I think most of our patient will fall into the category of high risk, and it also depends what definition we are using. So if not falling in the category of chartered, I am damn sure that most of the patient will fall in the category of latitude. So all high risk patient, the triplet therapy.
So that is what I wanted to either criteria, if they meet, they are high risk for us for both usage of docetaxel plus Abira.
So if high
Is
risk,
the right?
so you are asking for my choice for high risk.
So I'm asking you, say an individual has only, sir, vertebral or pelvic metastasis plus Gleason score of 8. So by latitude, the individual is high risk. Would you say so I know a lot of us prefer a triplet. Would you offer that individual a triplet now?
Yes.
Dose
Yes,
plus
I will.
Abira plus.
So if you see the piece one, it is not only the high risk, even low risk patient are also benefited. So
given the drug.
So I have decreased my, the threshold for giving triplet now.
So essentially, Rajesh sir, your view on it, and as we move forward.
No, I was giving triplet only,
how
but now these guidelines, they have taken out triplet in many things. Even ESMO and NCCN, what I was seeing, triplet was not given as a category 1 recommendation.
Oh,
for all, like
any specific reason, I don't know.
The reason I couldn't find out, but today only I checked, they have taken out the category 1 recommendation for like in high risk patients. So we should, I think we'll review it. We should review it.
Dr. Rakesh or Dr. Satvik, if you have a view on this, I am not aware. If I, for my last reading, I remembered that this remained the modality of choice.
Checked recently for triplet versus doublet, but in my practice, most of my patients go for doublet only. Somehow I'm unable to offer triplet because most of the patients I'm seeing are 75, 80 somehow. I don't know. So triplet, I rarely am able to give. And if I counsel about abiraterone or enzalutamide patients, I don't know, they do not agree for adding docetaxel to abiraterone. That is my case.
Anup, if Anup and then Satvik in that order, if you have to give docetaxel, do you give it 3 weekly for most of your patients? A 75 milligram per meter square 3 weekly dosing, or do you make it 50 milligram per meter square 2 weekly? So
that
not
is
the part of the trial, but how do you do it in your real life?
Mostly, sir, I try to give 3 weekly patient 3 weekly 6 cycles. But if a patient is very old, like more than 70 year and frail and has multiple comorbidities, then I go for 2 weekly. But I try to go for 3 weekly.
Yeah, I agree. And if I talk about triplet, then if I'm giving a triplet to a patient, then I'm assuming the patient is fit and I'm considering him fit. So I would prefer 3 weekly. But otherwise, if I'm only giving docetaxel, then a lot of it depends on patient's fitness. And I can change to 50 mg 2 weekly.
Dr. Vikas sir, Dr. Rajesh, मेरे को लगता है I'm the only person who prefers 2 weekly.
Yes, so I'm 9 doses 2 weekly. Like 90% of patient will fall in that category. Hardly 10% will receive 3 weekly. So 9 doses.
I am happy that I have a companion.
I concur with Satvik. If I am choosing triplet, then I will give 3 weekly. If a patient is not fit for triplet, then I will give abiraterone or docetaxel. I will choose one.
So sir, just for food of thought, I thought we know that 75 milligram per meter square 3 weekly versus 2 weekly 50 milligram per meter square are comparable regimens. And it is far better tolerated at 50 milligram per meter square. Just a food for thought. Why would you not want to change to 2 weekly? Anup, Satvik, Rajesh sir, Dr. Rakesh,
So,
anybody who would take it.
First of all, I'm not very comfortable giving triplet to all patients in CSPC.
Okay.
And if
Great.
if at all I'm giving triplet, then I assume patient should be fit, very fit, young. So then he will tolerate 3 weekly also. He should not come every 2 weeks. That is what I believe.
Sure. So as a summary, if I could gather from the house, is that castrate-sensitive prostate cancer is usually ADT plus something unless it is truly low-risk disease. A lot of us, if for fit patients, would prefer a triplet over a doublet. And then there is difference in terms of the acceptance of the patient in terms of triplets versus doublet. Do I draw the right conclusion? Thank you. So, to summarize, in terms of androgen deprivation therapy, we know that there is difference in mechanisms of both. The choice essentially surgical versus medical is driven by the cost and the compliance. The choice between the antagonist and agonist, as our colleagues rightly pointed out, is driven by the risk of the flare. Some of us also choose it based on the cardiovascular risk. That for the castrate-sensitive prostate cancer, non-metastatic, for biochemical recurrence, we do not usually offer an ADT. Most of us would offer continuous ADT over intermittent ADT. In high volume disease, it is always ADT plus something. Some of us have shifted to triplets completely. Some of us prefer doublets over triplets based on the fitness. Low volume disease, though a minority in our practice, continues to be ADT alone. And thank you for being a wonderful panel. And with this thought, I'd like to end the conversation. Thank you. If anybody has a final word, please pitch in. Dr. Vikas.
Yeah, thank you. So before
So, Dr.
we
Akash, actually,
leave the meeting,
I have
sir,
one comment.
continue, sir.
Yeah.
Yes.
So I'm just checking NCCN 2025 version 2. And for high volume synchronous or metagram metastasis, what they have recommended ADT with docetaxel and one of them. And all are category 1 abiraterone darolutamide, and both are category 1 with docetaxel.
Both are, no? So agreed, sir. Thank you, sir. Thanks for that clarification.
Dr. Rakesh also wanted to say, because we are.
Actually, only one point I want to ask regarding the uh, pattern of the PSA response when you are using with the ADT. So, suppose a patient on the ADT plus EBRA or the ENJA, the PSA does not comes to the normal; it comes to the 3 to 4. So these are the patients where even in the low volume disease, I do use docetaxel as we do not get the proper response with the use of only hormonal agent. So are anyone doing this kind of practice?
So,
Dr.
sir,
Akash?
this is interesting. So, sir, this is a very interesting thought. But I in my practice have then continue them with the same agent, and when they progress, we add docetaxel. But this is an interesting idea. I would consider it sometime. But in my practice, I usually give them continue with the same agent and would add another agent or would change the agent at progression. That's how I would do. I'm not sure. Probably Anup, Dr. Vikas, Dr. Rajesh, Satvik, sir, somebody could pitch in.
So I think few things I have learned from Joshi sir from TMH, and slowly I followed what he suggested, that the patient may not be fit for triplet therapy on day one. So start the ADT and Aviratron and wait for 4 to 6 weeks. And in 4 to 6 weeks, the back pain, the bony pain will disappear. The anemia with patient usually present, it also recovers. And then you add docetaxel. So, like I'm practicing this, and most of the patient during this 4 week or 6 week, the PSA will decrease to the range of what Dr. Rakesh has suggested.
Yes, sir.
Dr. Akash, sir?
Yeah, so I think he had his point. We can conclude if there is no remark or anything.
Yeah.
Hi. So sorry, I had to pick a call. इसलिए we can conclude. I switch over it.
Okay. So Saurabh, over to you.
Yeah, I would like to request to Dr. Rakesh sir. There is a questions from the audience. I can see in the chat box. So in the metastatic prostate cancer, especially in bone and lymph node, diagnosed with 10 years back, underwent bilateral orchectomy. Now came with urinary symptoms, imaging, so on recurrence in prostate alone. So we will consider for the local radiation. So this is the questions.
So, yes, in this patient, we can consider for the local RT because there's no disease elsewhere in the body outside. Yes, but we also like to add the second hormonal agent like the enzalutamide according to the comorbidity what the patient is having.
Thank you, sir. Thank you very much. So with that, I would like to request Dr. Sanjay Kamble kindly conclude with this nice osmosis, and especially the nice discussions of Dr. Akash Tiwari sir as well as Dr. Neeraj Bhatt sir, and their engagement, as well as all the panel members today. All of them was extremely good actually in terms of their engagement and their expressing their insights for different type and different cases of the prostate cancer, whether it is castration resistance prostate or maybe castration sensitive prostate cancer. With that, I'd like to request Dr. Sanjay Kamble for the vote of thanks. Thank you.
Thank you, Saurav, and really it was a wonderful discussion. Dr. Akash sir has navigated it very well. Most of the points were very well covered, and of course we had a lot of good attendance. In fact, wherein I hope that these scientific forums are really
Yeah,
helping
as
the.
of now, we have 150 attendees, means audience, not only in India, but also some of like Philippines and from different countries. They are attending now and they are watching the live sessions in India, where the most importantly, the case-based discussions we have only instead of any other topics, only for the case-based discussions we are discussing now. And we are having and we are noting the individual experience of their treatment and their practice.
Yeah. So in fact,
Thank you all.
that was a wonderful discussion. I thank all of the panelists, panel members, the moderators, and the program directors for their active participation and sharing the thoughtful insights on this very interesting topic of prostate cancer. And Samartha has always believed that these scientific forums really helps the people. So we really look forward for many such programs with all of you. So thank you all of the panelists and the faculties who could join us on their busy Saturday, and of course my colleagues from the marketing and the field people who have been backing up this program, and of course my side here, not the least. So thank you everyone, and
Yeah.
have a great day ahead. Thank you.
Thank you very much. Thank you all. Have a good night.